So first of all, congratulations, you've got this far, and there's a lot of overlap with some of these talks, so I'll be brief. But you've all done so well to get to this point, and really embrace the first few, particularly the first few weeks when you come in. It'll feel like you're not doing very much, you're just there meeting people and getting a feel for land, and really enjoy that time of settling in and get to know your colleagues well, inside work and also outside of work. That's really important. And all the other things which have been discussed. For me, I'd come to a completely new area. I trained in Manchester and Lancashire and then got appointed in North Wales. And I know the area from going on holiday, but didn't know much more about that. So I rented first a house for 12 months till I properly knew the lay of the land. And that was incredibly useful. You get to know the schools, the commutes, the area, and what kind of place you want to live, and so on and so forth. So plan ahead. Very important. And I'll briefly touch on this, have a life outside of work, and I'm still working on this bit, try and avoid too many unnecessary late finishes at work, and try and get home to your family at a reasonable o'clock. And this is my family, and I've made lots of sacrifices to get where I am, and they've come with me every step of the journey. I'll never forget that. Take them along with you, and stick to it. Now, I like this slide because we all think, this was me, I thought I was Top Gun when I got appointed. I thought I finished my fellowship, I've worked with Miss X, Mr. Such and Such, and I've seen it, I've done it all, and you think you're invincible and you can do it. But actually, on your first week and your first on call, you're more like this kid. Okay. And suddenly the fear will strike into you, and I remember my first on call week, I think I used the phrase, crikey, I haven't seen that before, at least half a dozen times. And this is a recurring theme, but this would be the thing I wish I'd known, because I didn't know how to say no. And I said yes to everything my first 2 years. And before long, I was clinical lead for trauma within a year. I was sat on this panel, that panel. I was having this evening meeting, that evening meeting, on this steering group. I was seeing way more patients in my clinic than anybody else, and my lists were always overrunning. And every surgeon thinks they can do a case in 20 minutes. You can't. So just be honest with yourself. Okay. And it's much better to finish a list at 4:45 than at 7:30. So just bear that in mind. Because if you do have a problem and you do have to run over, then you're not doing it every week. And those people will go the extra mile for you. And remember, there are only so many hours in the week. And if you do want to do more of these, make time in your job plan, which James will I'm sure, address in the next talk. And this has been a recurring theme as well, and please embrace your humility. Ask for help, do joint cases, and don't underestimate any case. I've learnt this the hard way as well. You've done a case 50 times, right? You've done 50 times in your logbook. You do your 50 first, and it's subtly different. And if you're not prepared for it and you feel you're on automatic pilot and you don't have that attention to detail, it will bite you in the arse. Okay, so always try and be objective for every single case. There's no such thing as minor surgery. Okay. And the other thing is, don't pretend to know the answer to everything, because you haven't got the answer to everything. And particularly, again, you finished your fellowship, you think you know everything, and you've seen that patient who's had 3 or 4 opinions from other people. And you may have written a paper on what this patient's come in as, and you think you know better. And this patient may have had 3 or 4 surgical opinions from somebody else, and you think you've worked out what's going on. Please beware of that patient. I've fallen into that trap where you think you can solve the problem where somebody else has failed, and generally you can't. So temper your enthusiasm. And careful documentation. I thought the MDU session was fantastic. You will never wish you'd documented less. And I've been through a couple of complaints and things. We all get complaints, and you often think, well, I remember saying that, but I didn't write that down. And it happens every time, so always document everything. Document who you saw the patient with. Use chaperones and document them by name. And it's so easy to take shortcuts in your job, and just don't. Conflict. I've had a few conflicts in 6 months, and it's inevitable. And do try and remain professional. It's really difficult. And if you lose your temper, fine, lose your temper. But do apologise later. I lost my ride with one of my colleagues in the coffee room once. And, I went up to him the day later and apologised. I said, I apologise for losing my temper with you. It was very unprofessional. And we're still friends. you know. And if you hadn't apologised, that ill feeling would just linger on for days, weeks, and weeks will become months, months will become years. And we have memories. We're elephants. We don't never forget these things. So wipe the slate clean, move on. And it's so important to do that. Escalate to others if you feel aggrieved, and accept criticism. If you're wrong, accept it, and you will get more respect for it. And this is a classic as well. Who's done this before? Sent off an inflammatory email when you're really, really angry and cross. Okay, save it, come back to it in the morning. And then 9 times out of 10, you'll change words or you'll just delete it. Okay, and also I've learned, I don't even send inflammatory emails anymore. Speak to people face to face. Ring up your colleague, ring up your medical director, ring up the nurse in charge and talk to them face to face rather than send emails. Because we send emails and we say things in emails that we wouldn't say to people face to face. And be honest. I've said this before. How many patients can you see in clinic? How many cases can I do in the day? And monitor and augment the above as needed. And also, another thing, I was seeing everything when I first started, and I realised, well, there's people in the region who do this better than me. So I'm not going to I'm not going to see that particular problem. I'm going to transfer that one out to an individual. And it'll make your life so much easier. So don't think you can do it all. So stick to what you're really good at. When I started, I'm a hand and wrist consultant predominantly. And when I arrived, I was doing some shoulder work. And I realised, well, some of my colleagues are far better at shoulder surgery than me. So I just made a decision, I'm not doing shoulders. Leave that to somebody else. And that was the best decision I've made. SPA activity. Now, this is a bit controversial. I feel I did all of these things, and I'm still doing all of these things in some regard, but you're either an educationalist, a researcher, or a clinical leader / manager. I think to juggle all of those three, for me, was quite difficult, particularly with a busy clinical practice and family life. And to stick to one and do it really well. And if you want to move into other areas, then that's fine. But just be aware, juggling is very difficult without your clinical practice or your family life suffering. And complications that have already been discussed. But I would say, please look after your complications really well. Apologise, we've discussed. And this is a classic. Bringing patients back when you're not there. Patients are not doing very well. And they always seem to come when the boss isn't there. And try and plan for that. If you see someone in the clinic and you think, oh, they haven't got a brilliant result, I want to see them in a few weeks. Get your diary out, have a look when you're there, bring them to a specific slot. And don't let them wait an hour and a half in the clinic like everybody else. See them on time. That's another pearl that I've learned the hard way as well. Because then they're even more cross by the time they come in to see you. And deal with complaints quickly. The other thing I do is I triage my own clinic. As soon as I come in, I need to see that one, I need to see that one, I need to see that one. The registrar can see these, the extended scope practitioner can see these, and stick to it. And that's really helpful and it saves you time. And I didn't do that when I first started. It was just a sort of free-for-all. And if you make a mistake, the acronym I was taught by one of my mentors is RAMA. So what that means is if you make a mistake, you have to recognise it first of all. You have to admit it to the patient, and most difficultly to yourself. You have to mitigate it. So do something about it. If you can't do something about it, it's outside your area of expertise, then send it to someone who can sort it out. And of course, apologise. Changing things. I wanted to change everything when I first came along. I thought this hospital could do better, and I wanted to move forwards. Change takes time. And be patient. Remember that you're a small cog in a big machine. But keep at it. Keep chipping away at it. And if you can justify what you want to do is better than what's happening now, and certainly if it's cheaper, then it will definitely happen. If it's more expensive, you have to do a business case. And that can be a minefield, and you need to seek expert advice on that from senior colleagues and your finance team. But I thought, I didn't realise changing things would take quite so long in the NHS, but it does. And innovation versus caution, this as well is really important for you guys. As something new comes along, you've been to the top meetings around the country, and you want to innovate, you want to bring in this new technique. And a lot of this is industry driven, and beware of the reps. I would say this, particularly we all use a lot of technology and a lot of implants and plates and screws and various things. The reps are not your mates. they are very savvy and they are very well trained, and they will come to you as their mates. But remember, they are ruthless salespeople with their own targets. So have a respectful relationship with the industry. Engage with them, but have this healthy relationship. And temper your desire to move forwards with what's best for your patients. And really stick to the evidence base and try not to follow this Scott's parabola, which I'm sure many of you are familiar with. But do innovate. Innovation is very important. And innovation is difficult when your training is competency-based. Because obviously competency-based assessment will only get you so far. And the next steps, that gives you your baseline of surgical sort of ability. But often you will have to innovate to move forward. And private practice is briefly touched. I don't want to talk too much about private practice. I have a very modest private practice. And I started about 18 months after becoming a consultant because a lot of patients were asking me. There was nobody in my area doing hand surgery, so I started. But I thought I didn't anticipate how awkward it is. You've got to be really organised. And I was doing my own books for the first couple of years, which is such a pain. And get a good accountant. And keep it sounds really obvious, but keep it in a completely separate entity from the NHS. I'm not meaning in terms of time. But I started out, my NHS secretary said, well, I need some overtime. Can I do your private letters? I'll do them at the weekend. And I said, great, fantastic. And it just didn't work out. Just didn't work out at all. So keep it as a completely separate entity. And when things aren't going well, we all have days like this. We all have days like and you have to be prepared for them. Anticipate your human factors, because when something goes wrong, there's always a reason. So, for example, I cancelled a big case last week because my daughter had chickenpox, and I was up half the night with her. And I just was honest with the patient. I don't feel well enough to do your procedure. I hadn't had enough sleep. So I'm going to cancel you. I'll do you next week. I sincerely apologise. Remember, do no harm. It's easy to do. It's easy to fall into that trap, and I've done it before. There is no shame in bailing out. Okay? Far better to bail out than do something when you're not in the right frame of mind. Walk away from the table. If you're trying to do something and you just can't see the wood for the trees, just step back. I'm sure more senior colleagues will advise this, but just walk away. Walk away from the table. Take a moment, take a breath, have a sit down, leave the theatre sometimes, if obviously the patient's stable, and call for help. Your colleague may be next door or in the clinic, and just say, mate, I'm struggling, can you come and just give us a hand with this, or just what are your thoughts? And I've never had a death on table. My colleague recently has had a death on table, and it is harrowing. And if it's an unexpected thing, then take time off to gather your thoughts. There is no shame in that. Diolch yn fawr. Thank you very much.